And thank you for switching to Teams today, much appreciated. So because we're all joining remotely today, so I only just need to read out just a little preamble for those joining remotely. So cameras for all councillors attending the meeting, cameras to be left on, but your microphones muted. If you wish to speak, press the virtual hand on the screen and begin to speak after I invite you in. Bear with me. The last meeting I chaired on Teams was June last year, but I'll do my best to make sure I see you all in order. And okay, so all officers and guests will join you remotely. If you can all turn your cameras off, so only councillors can be seen on screen. Great, thank you. Okay, Clive, are you okay to turn your camera on, please?
Oh, I beg your pardon.
Oh, that's okay.
I thought I was on. Ah, there you are. Can you see me now?
I can't see you. Maybe
Oh.
I know we've been having some issues with some cameras. But you can hear us, yeah? Oh, there we go.
Yes.
Hang on. Yeah, I think you may have an issue with your camera, but I can see that you're there. That's fine. Okay, so we've started recording. Lovely. So, Prynawn da, welcome to Social Services Scrutiny Committee on Tuesday, the 24th of October, 2023. Please note that this meeting is being recorded and may be broadcast via the authority's internet site. The images and sound recording may also be used for training purposes. Okay, so agenda item 1 is apologies for absence. We've had apologies from Councillor Claire Jones, and that is it. The rest of us are here. Agenda item 2 is declarations of interest. Does anybody have an interest they wish to declare? No. Great. So agenda item 3 is hospital pressures and discharges, and that's on pages 5 to 10. So I believe Cabinet Member Julia Jenkins is going to introduce the report and then hand over to Angela.
Thank you, Chair. It's the Scrutiny Committee report, update on hospital pressures and discharges. Summary report. A report presented to Scrutiny in October 2022 and Scrutiny as requested by the Scrutiny Committee. This report outlines the relationship between hospital discharges and adult social care and the update position in October 2023. The report outlines the pressures that had been experienced by both health and social care and the impact on discharges and the actions that have been undertaken. And the recommendations of that Scrutiny note the contents of the report. Thank you.
Thank you, Councillor Jenkins. Angela, are you okay to take us through the rest, please?
Yeah, thanks, Chair. If you look at the introduction and the background, I think Councillor Jenkins just covered off and saying there's an update as requested by Scrutiny from previous report that we brought. As you know, there's a clear interdependency between adult social care and health. And, you know, sort of they work together to support people when they're unwell through the system and back home or to an alternative place of residence. If you look in 3.4, well, you've seen that there's a decrease in the number of people who have been admitted because of COVID, and that has lessened, so the pressure from there has significantly decreased. But the biggest point is in 3.5. Previously, we've always experienced increased pressures through the winter months. You know, we all know things like, you know, sort of the weather will impact on people with, you know, sort of long-term chronic respiratory problems. But what we're seeing in the last couple of years is that it's not so much. It's actually pressures throughout the year. And, you know, this week again, you know, Monday, Cwmtaf went into the position where they were on the borders of announcing business continuity yesterday morning because of the pressures and number of people within the system. So that just illustrates it's not just winter anymore. Where we were, again, we just said around that change to the experience of winter pressures being throughout the year rather than just in the winter period. We've seen increased pressures within our domiciliary care service, and what we've seen is a change from the number of people who were needing dom care going from single-handed to double-handed. So we've seen an increase in complexity of those people, which is also another issue is that they've been unable to recruit. That's we were, and we've been working with our commission providers to try and deal with, sort of an increased capacity there through commission additional framework providers to increase the ability to take packages in the community. Our care management services that support discharge are fragmented across the teams. So what we see is there's some in the adult team, there's some in the duty team, there's some in the mental health team. So it is spaced across all our care management teams. Our communication with wards sometimes could be is not as robust as we'd want it to be. And if you look at the basic fact that social workers go out into the community and the ability to speak to people on the board because they're busy, it exacerbates that ability for that, sort of really strong flow of communication to aid people moving through the system. Previously, we did in a previous report, we highlighted, around the 6 goals of unscheduled care. So I'm reiterated that in this report because we've already covered that a significant amount degree previously. Where are we now? Pressures continue. We see lulls, we see increases, and it doesn't seem to be, sort of associated with any time period. It seems to be across the board throughout the year. We've seen an improvement in the capacity of our domiciliary care providers, mainly through our increased framework providers providing additional hours. And we've seen pretty good capacity in the last few months, though it seems to be slowing down as that increased capacity has been taken up by people coming out of hospital with more complex care and in the community. We, as far as the 6 goals, I've highlighted there some of the areas that we've currently been working on. One is the development of a primary care navigation hub, and that is through primary care, look and see what they can do to actually prevent people going into hospital, and that seems to be working quite effectively at the moment. The development and implementation of an electronic transfer of care document, which is known as the TOC now, but there's still some issues there, more around the IT element from health colleagues, but they're continuing to work through that. Revised community care model has been developed that is based on unscheduled care and on long-term support for people in the community. And the discharge pathway has identified for everyone admitted to hospital within 48 hours under the discharge to assess arrangements. If you look at it, point 5.4 covers off around the change in our reporting of what was previously known as delayed transfer of care or DTOC. They've now been retitled Pathway of Care Delays since April this year, and these are now being reported through Welsh Government for all Pathway of Care delays across Wales. For Merthyr, the key areas I've indicated in the tables, the highest number of delays, and this was taken from September 23 because we've only just looked at the October ones that are currently being collated now. And we can see it's waiting of completion of nursing assessment. AHP is allied health professional, so that's the community OTs, physios, etc. Waiting for completion of assessment by social care, waiting for social worker allocation, care home packages, but these are all built on one day, which is third Wednesday of each month. So if a discharge was planned for the Thursday, they would still appear as a delay waiting for a package of care on the Wednesday, because that was when the census has been undertaken. So these are pretty much, if you look at it each month, they're more or less similar numbers all the way through. Okay, if you look at it, the reporting for 6 months, and then up at the top 10 for the region, which aren't exactly the same as for Merthyr. But as a regional arrangement, this is the top 10 that we've been looking at to see what we can try and do to improve the current position. The key themes are waiting completion of assessment, whether they be by health or social care, waiting for the start of a new care package, but as I've already explained, that could be that even if it was the next couple of days, they would still show us waiting for that. Waiting for availability within the care home sector, and that's across nursing and residential, though we do see the majority are waiting for nursing placements. There are a few working groups now being established to look at how we can address these delays, looking at, you know, sort of capacity, looking at, you know, why is it there's a shortfall, or we waiting for the completion of assessments, and they're looking at things in more depth rather than just the highlight numbers that you can see there. We've sourced funding through the Regional Integrated Fund support to the development of supported discharge and discharge to assess team for Merthyr Tydfil, and we'll cover that off in a bit more detail when we look at the new adult structure. We've now recruited into those posts, and it's anticipated they'll all be in post throughout the month of November, but that's due to sort of people's notice periods. We normally receive additional funding. This is the key issue, is every year we receive additional money from Welsh Government to fund increased capacity across health and social care to support our winter pressures. But we've been advised this year that there will be no additional funding, and there wasn't any additional funding last year either. And that's in sort of line with the pressures on budgets within Welsh Government. We recognise that delivering services in a more integrated way between health and social care can achieve improved outcomes, and that's in line with Further Faster. And we've currently just appointed a new regional director for integration for a 2-year period to support the region to take that forward at a greater pace, and it's anticipated they'll be starting in November. Where do we want to be? We want to be in a position where social care and health services work together to provide better outcomes for people. And we want to have systems in place across social care and health services that support discharges and prevent people remaining in hospital longer than necessary. So next steps, we need to develop a regional implementation plan, and we've got a meeting tomorrow to go through that. And we need to continue to work around the 6 goals programme, and we need to consider what actions can be taken to address the top 3 reasons for the pathway of care delays across the region. And we are planning how we work in a more integrated way to maximise the resources that we have to provide better outcomes, and it contributes to the wellbeing plans, as you can see there. So I'll leave it open if I...
Thank you, Angela. Open up for questions. First hand up, I got Councillor Ian Thomas.
Thank you, Chair. Angela, I just got a couple of questions for you. I can see the progress is being made. On point 4.4, you indicate that there's a sort of a problem with communication between social workers and the ward. I was wondering if you could clarify that a bit, what these problems are, and could it be like the change in shift patterns of nurses and you don't get the same person like when you ring the hospital and things like that? That's the one question.
Thanks, Thomas. I'll answer that. It's basically some people are office based and some people work in the community. So if you look at it, and probably a simple example to illustrate is social worker may ring the board today and say, is it okay if I come and assess Angela? And the nursing staff will say, well, they're not really well enough for assessment at the moment, but we let you know when they are. So you end up then with the social worker waiting for a call from the hospital, and then the hospital waiting for the social worker to come. So it's just a sort of slight communication. It may be then a week before they think, oh, well, I haven't heard from the social worker, so I'll try and ring them. So then the social worker will be sitting waiting for the hospital to contact them. So it is slight issues with communication, or the social worker may try to ring the hospital and they're so busy, there's no one answering the phone. So, you know, there's small things, but then what we put in place to try and address that is our supported discharge team. So they actually have a presence on the board, so they'll be able to get better updates. Hope that answers your query.
Yeah, that's fine. Thank you very much. The other one, if I may, is on point 5.4, where you list the statistics showing the different reasons for delay of discharge into the community. And the first one, which is quite a large number, internal hospital reasons, 8. And I just wondered, in view of the fact, if this is entirely to do with what's going on in the hospital, they're not really ready for discharge, are they? And there's nothing that the social services can do about it. And I was just wondering whether that sort of spoils the stats in a way, or whether they should be not there, but maybe somewhere else.
Thanks, Councillor Thomas. The delayed, the package of care delays record all reasons for people not being able to move on to the next stage of care. So whilst they're allocated to a local authority because that's where that person resides, it wouldn't be fair or appropriate if we just said that people are delayed in the system for social care reasons. So there are reasons that people in the system and not being able to flow through to discharge, they're down to health as well. So it's not only, you know, it's to illustrate that when you look at it, when you see it in the media, it's quite often portrayed that it's all social care reasons, that people aren't being able to be discharged, but that's not the case. And this actually illustrates there's people waiting for assessment from other professionals and not just waiting for the outcome of social care assessment.
Yeah, so shines a light on it.
Yeah, so it is right that they're there. So it does balance it a bit more. That it's not all social care reasons that people are waiting to be discharged.
Yeah, thank you, Angela. Thank you, Chair.
Yeah.
Thank you, Councillor Thomas. Angela, going back, following on from Councillor Thomas's question in relation to communication, because I know in 5.7 you mentioned obviously you've secured the funding for the supported discharge and discharge to assess team, but of course, like that's not, you know, that's not in place yet, is it? So it'll be November, there'll be a period of embedding in, etc. So my concern is what happens between now and then, especially if there's a delay because some people change their mind when they take a post. Or, do you know what I mean? What's the resilience at the minute while you're waiting for that to kick in?
In all honesty, I think we revert back to what we're using. I think the difficulty we've got is if you look at it, we use email as a sort of strong form of communication. We can't get hold of someone by telephone, but there's, because of the wards, they haven't got generic ward 4 or ward 3 email addresses where you could like email in to say what the update is. They've been doing a lot of work in terms of called the one list. And one thing that we've all been trying to do is like say, what is the one version of the truth? So the reason that person can't move on to that next step. So they've developed something through that e-track, which is called the one list, where there's information on there. And we've been looking to see if there's any electronic systems jointly that we can put in place to try and get that information flow working more effectively. But it hasn't been, you know, it's taken some time to embed a new electronic system. So I think what we'll end up doing is still trying to sort of catch people in between and trying to update. What I'm saying is not that the communication is non-existent, it's just that it could be much better than the current system of hoping that, you know, the board staff and catch a social worker who may be out that day versus, you know, sort of us trying to contact the ward. And I know there's been instances sometimes where social workers are ringing. We've raised that as part of, like, through the integrated discharge board, and the fact that the ward staff are so busy, some
Angela?
just went a bit ropey. Can you hear me now?
Yeah, we missed the last 30 seconds there then.
Oh, right. What I was going to say is that we just can't, if the social worker can't get hold of the board, what they do, they try again a bit later. Do you know what I mean? But sometimes it might be the following day. So it all adds up when you add in one day here, half a day there, or a couple of days. So, it does have an impact.
Okay, I got one more question, then I'll hand over to got Gareth Richards next. So when you look at those reporting of delays, are they individually unpicked then and tracked back of
Oh, right.
do you know what I mean?
Yeah.
Just to actually, because I know you've said, some of the reason is health, etc. But also, are they specifically tracked all the way down to so you know who that allocated worker was? Just
Yeah.
I'm just thinking lessons learned and things. Is you can be more specific when you look at it. We've lost Angela again. Angela?
Yes, I was having difficulties as well.
It's okay. Oh, there we are. She'll probably rejoin now. Bear
Yeah.
with. We need hold music.
Yeah,
Hopefully she'll
I don't know why
rejoin.
my camera decided to work in the end.
Sorry about that. It's like I can see you all moving, but it wasn't.
all right.
From my end,
It's
it
okay.
was like not working.
It happens. It's okay.
Yeah, it's an onerous task, to be honest, to collate this. So the census is undertaken on the third Wednesday of every month. So you get all the health staff going round and looking at everyone that's in the bed on that day. Then they look at why is that person in that bed, and is it that they're medically optimized? If they're not medically optimized, then they should be in that bed. So once someone is identified as being medically optimized or fit for discharge or fit for going on to the next stage of care, then they look at the reasons why that person's still in the bed. So is it they're waiting for an assessment by a nurse? Are they waiting for medication? Are they waiting for something else? So these are done on individual. So in the first instance, the lists are identifiable people with the names. Yeah. So we know who we're talking about. Then they look in the first instance to say what is the reason, and then there's a number of codes, much more than there's just shown on there because it's just the top 10. So it'll be all the codes then, and then they come and validate it with each local authority. So for all the people in Merthyr, we'll get a list of everyone's in the bed in Merthyr and what that reason for them being there is and why they can't move on. So then that's when there's that negotiation. They'll agree what that code is.
Okay, we missed about 10 seconds of that then,
Yeah.
Angela.
It's basically that's where the negotiation takes place, and
Okay.
then we agree between health and social care the reason for that delay, and then that's put onto the system. Then that's submitted to Welsh Government at the end of within 1 week. So it's only about 3-4 working days. So it's really tight turnaround. When you
Okay.
think of the numbers, it's significant. So I know health colleagues really struggle with getting all those numbers in.
Thank you, Angela. Councillor Gareth Richards.
Thank you, Chair. Another one for Angela. It's in relation to the non-easing of pressures, Angela. Is there any specific?
Gareth, you've muted yourself. Lovely.
Right. Sorry, Angela. I'll start again. It's in relation to the non-easing of pressures. Obviously, they used to occur quite regularly in winter months, didn't they?
Mm.
Is there any reason why this has become now an all year round occurrence then, really?
No expert, but I would suggest that one of the reasons is we've got a far older population than we have previously, that they're older, but they're not well older people with health needs, and that requires them to go into hospital, you know, sort of number of people who are in and out, you know, before is, you know, sort of significant numbers. Most of the people we're talking in the delays there are all older people. They're not very few younger people that are in those delayed pathways of care.
Is it okay for another question, Chair? Or?
Yeah, carry on.
It's in relation to recruitment and retention problems, I think, really, in the care sector.
Yeah.
Again, whilst I still don't believe they are being rewarded as they should be, but there has been some improvement in sort of terms for them. Any reason why there is this recruitment and retention problem?
I think partly a lot of people, and I think we reported this previously in terms of domiciliary care, a lot of people left the sector following the pandemic. You know, there's an increased number of posts out there that are paid similarly, retail, etc., hospitality, with less responsibilities. If you look at it, 15 years ago, dom care workers probably went in, did a bit of shopping, did a bit of cleaning, would often do someone's hair, sit there and have a chat, and, you know, didn't really do a lot more than that. But if you look at it now, you're talking about really complex packages in care. People who are unable to get out of bed, you know, they're receiving 4 calls a day, double-handed, you know, much higher care needs than they would have a number of years ago. And I think when the pandemic hit, a lot of the staff felt they were really sort of under pressure. They saw a lot of people dying more so than they would have. And the pressures and stress when a lot of people left the sector. What we're seeing at the moment, there are more people coming back, and touch wood, I don't want to preempt too much, but, you know, there seem to be more stability in there, but it's across the country. This isn't just a Merthyr issue. And in fact, I think if anything, Merthyr has been pretty lucky for a long period of time, because we didn't see these issues until, you know, sort of quite, well, when I say quite recently, in the last couple of years.
Yeah. Can I have a follow? Because I was glad you mentioned other parts of the country. I read some articles, Angela, that possibly Brexit has been a cause in some parts of the country. That care workers, perhaps from overseas, have returned to their home countries.
And that may be an issue elsewhere, but if you look at it, I don't think in Merthyr that we've got a high number of care workers from other, you know, sort of from the EU. Though I'm sure there's some out there, but I don't think it's the same as if you're looking in, you know, sort of really urban areas, such as Cardiff or Swansea or Newport. So it has had an impact in some areas. I don't think it's had a significant impact for Merthyr, basically because for some reason the general workforce of Merthyr tends to be, you know, sort of people from the local community.
Yeah. Just to follow up, and then I leave Clive come in. And I have got another question, but I leave Clive go first. But what do you class as the rural areas? I'm intrigued with that. I suppose it's Clive's ward and the southern end of the borough, I suppose, is it?
It's going to be easy to say. It's like Ponstick and Glenard. So what you've got is that, you know, you might, and where they really struggle, there may be like 1 or 2 calls there. So the balance for domiciliary care is always to provide enough work for those people to make it worthwhile. So if you only had 2 calls a day or 4 calls a day, then and you were working, that's not really a, you know, sort of sufficient wage. So it is that balance between not overworking people, but getting enough work to warrant, you know, them wanting to work in social care.
Thanks, Angela. With your permission, I'll come back after Clive if that's okay, Chair.
Yeah, that's fine. Absolutely fine. Councillor Clive Tevye?
Yes. I was wondering, does the hospital employ a social worker, or are they all employed by the council?
The They don't employ any social workers. There is a facility to employ them. I think under, when they did the Gender for Change, and there's a job profile, a role profile within there for a social worker, but I don't think any authority, any health boards Contact Morgana aren't employing any social workers.
It strikes me, to improve communications, if there was one person based at the hospital all the time or for a few weeks at a time, it would help things dramatically, I think, rather than having to sort of email out or contact people individually, But
in times of extreme pressure, we've actually sent one of our staff up there to work with the discharge liaison nurses to actually see, clearly see what needs to be done next. And from that, we identified that it was really beneficial for us. That was one of the that really influenced our moving towards a supported discharge team that will spend part of their week in the hospital. I know it's gone again. There's the fact that having someone there is benefit discharge team. So Raz had to factor in there, because we did find that communication improved when we were able to put someone in the hospital.
Oh, thanks. I was going to ask as well, how well does this navigation hub work?
Kelly's got the lead on that. It's only, well, I didn't put too much detail in there, but Owen Weeks has got the lead on that from Health. It is additional GPs. It's probably aligned very much with the site of the out of hours GP, which is over in Ely. They will look to see if they can support someone rather than the conveyance going in there. And in times of intense pressure for ambulance, they'll also start looking at people who are on the stack to see if there's anything they can do to try and prevent them having to be transported.
Lost you again, Angela.
Can you hear me now? Because I can hear everyone else.
Yeah, you just keep freezing.
Sorry.
It's okay. You aren't going to apologise. It's something out of your control. It's okay. It happens.
It's been fine all day. It's ironic this afternoon. I think he's just given up now, because I've been on calls all day and it's been fine. But it just seems to be at certain times it goes a bit ropey. They have done an evaluation of the impact of it. He's been successful in sort of preventing some people coming over to A&E. So it's been quite positive, but at this point it only takes referrals from professionals, and it will support nursing homes but not care homes at this point. But they are looking to extend that to residential homes at some point in the future.
Oh, thanks very much.
Thank you, Councillor Tuffy. Councillor Garth Richards, do you want to come back in there? Yeah,
thank you, Chair. Angela, it's in relation to paragraph 5.7, my question is the new team that's been put together.
Yeah.
Can you explain what exactly we're doing to improve the situation and number of staff involved in that team?
Right. We'll cover some of it in the new structure, if that's okay, because it puts a rationale in there and what we've done and why we came to that conclusion. So rather than say now and then repeat it after, is that okay, Councillor Richards?
Yes. Yeah. I know. Yeah. It's fine.
Was there anything else you wanted to ask?
No, that's fine. Thank you.
Okay. Angela, with the 5.3, the pathway where everybody was admitted and within 48 hours, everyone involved is away. So can you talk me through that? So is it like the nurse does it and then it's shared out? So who takes ownership of that initial pathway, please?
I think one thing that's traditionally been undertaken is someone comes into the line in the bed, then the clinical staff and the doctors and nurses do what they need to do, and then they're better. Then they think, oh right, well, where's this person going to go, and what do they need to get them back home? Yeah. So it is traditionally, and I'm sure Councillor Tabb will support in this, is that discharge was seen as a separate issue, but when someone was well enough to think about the discharge. Yeah, so that would be essentially people were well enough to go home, but the discharge planning didn't start until they were well enough. What they're trying to do is start at the point of admission, and very early on is starting to think about what is going to be the discharge plan for that individual to make sure that everything's all lined up, ready for when they are well enough to go. So the D2RA pathways are then looked at as part of the multidisciplinary team that are hospital based, to say, based on what we know about this individual, the likelihood is, you know, if you went in for the broke and they set your leg, they'd be saying, right, okay, within 48 hours, they'd be saying the plan is they're going to go home with no support, and that's pathway 0. Maybe that when someone comes in, they're saying, look, you know, they've got a package of care, they're going to need that package of care when they go back out, so they'll allocate that discharge pathway. So it's as soon as they can make a decision, it may change, it's not set in stone, because someone could deteriorate or or someone can get a lot better, but it is an early indication of what they're planning for, whether someone go home or whether it's looking as if they're going to need a care provision.
Okay, so it's like the health, that's the initiative, they take responsibility for that. And then they would, okay, great.
So if it looks as if someone needs support, then what they do then is make sure that they make a referral to social care through the ETOC, so that then there's an allocated social worker rather than wait until they're well enough before they would refer to social services.
And would it be health then that monitor that if there's any issues with that not being completed? That's purely health. Great. Okay. Has anybody got any other questions in relation to this? No? Councillor Clyde-Tubby? You're on mute, lovely. Councillor Tubby, you're on mute.
Sorry, I thought we were going on to comments then.
Oh yeah, we'll go on to comments because there was no other questions. That's fine. We'll go on to comments.
No, I think that the reason we are so busy in the summer as well now, since Neville Hall A&E closed, the Grange A&E, people from Abergavenny and that area are supposed to go to the Grange. But the reality is there's a lot more people come into Merthyr and Prince Charles Hospital from outside technically from outside the area. And we've noticed we get a lot of sick people coming in from areas that should go elsewhere, really. The other thing is we're sort of a stroke centre as well. A lot of people with strokes that live, you know, towards the Royal Glamorgan now come to Prince Charles. And I think a part of the problem is as well, the paramedics have got some discretion which hospital to take people to, and quite often there's big queues at the Grange, and so they bring people to Merthyr. And the number of sick people we're getting now has dramatically increased, I think, over the past couple of years. And I dread to think what the winter's going to be like this year, to be honest.
Thank you, Councillor Tuffy. Councillor Gareth Richards?
Oh, it's just a comment really on what Clive said. Whilst I recognise that there may be patients coming from elsewhere to our local hospitals, that wouldn't have a bearing then on the discharge issue, because we're only looking at Merthyr patients, aren't we?
That's right. Thank you, Gareth Richards. I think my comment to this really is, and it kind of goes over to the other report in relation to the staffing structure with the team. I think, you know, because my concern is if there's delays, you know, and things getting embedded, and then new ways of working, And I would imagine it's not going to be perhaps November when we see those changes in communication, perhaps well into the new year. But those are my thoughts on that, really, because delays happen, don't they? Gareth Richards, did you want to come in with another comment?
My hand was up in the air, sorry, Chair.
Okay, lovely. Any other comments before we move on? No, lovely. Thank you, Angela, for going through that. You can rest your voice for a little bit now before we go on to the next one. So item 4 is the review and reconfiguration of adult services structure. And I believe that this is listed on the Cabinet Forward Work Programme. That's right, Julia, isn't it? And I think it's due to be presented in Cabinet on the 8th of November. So yeah. I'll hand you over to Councillor Julia Jenkins, who can introduce us to through the report.
Okay, it's the review and configuration of adult services structure. Summary report. It's 1.1. The report outlines the role of adult social care and how support is delivered. In 1.2, an outline of the previous management arrangement and structure. 1.3, the need for change and the changes that have already been implemented. And 1.4, the proposed revised structure. Purpose of the report, to provide scrutiny with the rationale behind the review and proposed structure for adult social care to meet the future requirements of adult social care. Thank you, Chair.
Thank you, Councillor Jenkins. Angela?
Okay, thanks. Thanks, Councillor Jenkins, for introducing that. If you look at it, adult social care is a collective term for everything we provide to adults through social services. And 3.2 outlines what we actually deliver through adult social care. And you can see from that it's quite diverse. It's around care management, we've got directly delivered, we commission services, we've got supported accommodation, we've also got responsibilities under the Mental Health Act. If you look at it in 3.3, I won't go into any detail, but it illustrates the number of people that we support through adult social care and the number of hours. So if you look at it, we provide 350 people support through domiciliary care, and it's around 3,500 hours a week, which is a significant number when you think of the sort of how small Merthyr is. The assessment teams in 3.4, you can see they take into account, undertake about 1,800 assessments a year, and that doesn't include the assessments under the Mental Health Act, which are not recorded in that, but they are, significant amount of work to undertake a mental health assessment, and often with our staff working late into the evenings to complete those. We get around 850 A1s, which is the safeguarding reports for vulnerable adults. And the structure of adult social care hasn't been reviewed in over 10 years to see if it's still fit for purpose. So we thought it would be a good time to review where we were and were we providing things in the way you should do, or should we change where we deliver services? If you look at it, we've already had an additional principal manager in response to the recommendation from the Improvement Board, and those are in place, but unfortunately the person who's employed in there is sought other employment, and we're currently recruiting into that post. We identified there was a key couple of pressures within the adult system that needed addressing in direct services and within the care management teams. Where we were, if you look at it, a number of years ago, there's been significant number of reduction in number of managers within adult services. And if you look at 4.1, that illustrates the management that was in place a number of years ago and currently where we are now. So is quite lean in terms of a structure. If you look at it laterally, each care management team at the team manager, and the team with 2 of these teams having a senior social worker, whilst the initial support team only had 1 manager, and they were responsible for oversight of the duty team and the occupational therapy services with no seniors in place. The structure of the care homes for older people consists of 1 registered manager with 4 senior care staff, 1 to take low-level elements of the management responsibilities in the absence of the manager. What we saw is the structure of the learned disability care home consisted only of the registered manager, with care staff undertaking some additional responsibilities in their absence. The fragility of that really became apparent when we had 2 of the 3 care home managers who were absent from work, and we didn't have replacement structure in place with, you know, deputy managers, and it did put a lot of pressure on us, and we were unable to meet our regulatory requirements under RISCA. Care management, people in hospital have been fragmented, as we've covered in the earlier report, and it's not been as robust as we would have hoped, and sometimes meaning that people will remain in hospital longer than they were able to. And we've also seen the principal manager and safeguarding left the authority a few months ago, and so we took that as an opportunity to review where we were and what would be the best way to deliver our safeguarding to adults going forward. In section 5, where are we now? We've already implemented some of the restructure, purely due to the fact that it was leaving us in, you know, sort of at risk if we didn't take that forward. So I've said already, the appointment of the additional principal manager, revision of the care home management has reduced from 3 registered managers down to 2, but what we've done then, within the same resource, we've replaced those with 2 deputy posts, and it's all within the existing funding arrangements. We've changed one of the community occupational therapy posts to become a senior post that had improved professional supervision for those staff and day-to-day management, rather than the one manager having responsibility for all the teams. We appointed a senior social worker to the initial support service. It was initially funded through the Integrated Care Fund, and we've now moved that into core funding. And there's an additional senior practitioner role within the adult safeguarding structure following results of inspection of adult safeguarding, with a view to assist with resilience across the service. We've also introduced a business support officer, which covers both adults and children. And again, that was a recommendation from the improvement board, so that's why those have already been put in place. We've completed a review of the caseloads of the teams to identify numbers of social work and assessment and review staff that are required in each area to meet the level of demand. And we've sourced additional funding through regional integrated fund, as the Integrated Care Fund, to develop the supported discharge and discharge assess team. And they'll work with the existing stay well at home and the discharge liaison nurses on the hospital sites to improve how we support people moving through the system. We reviewed the areas the principal managers are responsible for to ensure the more appropriate alignment of responsibilities, and those posts are currently being reviewed under job evaluation to see what the impact of that is going to be. We revised the Learned Disability Day service management, and we reported on that previously to Scrutiny around where we were moving with day services, and again within the existing financial resources that we've strengthened that management arrangement to have a manager and a deputy. We revisited how we deliver day services, as just said, following the pandemic, and restructured, and we reported that previously to Scrutiny. And we've undertaken consultations, discussions with staff across adult services and trade unions around the new structure. Then in point 6, we said we can see that this is the new structure with the head service, and we've renamed some of them to make it easier to see. So we've got the principal manager, and we've got the complex care advisor who provides support to all the teams. We've got a team manager for the CMHT, which remains unchanged for at this time. The adult safeguarding, we're looking to develop a team manager in there with the current team that is supporting adult safeguarding. team manager for the adult assessment and review team and senior social worker in there, and we're looking to move in some reviewing officers into that area, but they'll be coming from the front door teams. There's the senior COT, and already explained that that's been the senior for the duty and assessment team and the teams under there. The new area is the senior in the supported discharge team, and under there, in response to Councillor Richards's comments earlier, it'll be a senior social worker, 2 social workers at grade 8, and an assessment and review, and the discharge coordinator that's already in post. The next table illustrates the new proposed structure, and that is, most of that is actually in place, but we're looking to move in contract monitoring that will come under the manager for service provision. Where do we need to go next is to complete the recruitment into the key posts and supported discharge, and we've got started in response to Councillor Manette's comments earlier. They've all got start dates and all ready to start, so they'll be starting in the next couple of weeks. We need to recruit into the team manager for adult safeguarding, but we've got to get that post evaluated as yet, and we need to revise our processes to reflect the new structure. And again, this links to the wellbeing objectives. So if there's any questions?
Thank you, Angela. I'm conscious, Gareth, obviously, because you raised the staffing structure. Was there anything additional you wanted to ask? I think because we've just had that report in relation to the hospital. Do you want to ask that question first, or has Angela answered it?
No, I think Angela's answered it, Chair. Thanks.
Lovely. Thank you, Councillor
On
Richards.
that matter, anyway.
Lovely. Thank you. Councillor Ian Thomas.
Thank you, Chair. It's not a question, it's just a comment, really. Obviously, a lot of work's gone into the structure, and I wouldn't presume to criticise it at all. But I did think that the move to put the 2 care home managers supported by 2 deputies was pretty clever. So I just wanted to acknowledge that.
Thank you. It also provides resilience, but also succession planning. So, you know, it was a big jump from a care assistant into becoming a care home registered manager. So what it does, it actually provides opportunities for people to develop skills, so that we would have, you know, sort of people in place that should those care home managers leave, that we've now got people with some experience to be able to move up into that post.
Yeah, thank you.
Thank you, Councillor Thomas. Angela, when you've done in 5.2, when you've completed a review of caseloads of teams, you know, looking at to review the staff that were required. So when was that review done, please?
Probably about 6 months ago, where
Okay.
we've been doing it, but we've been sort of looking at it continuously. So we've looked at how many of those cases were hospital discharges and how many were in hospital. So we know it roughly ranges between 40 to 60 people are in hospital. So then on an average caseload of 20 each, then, you know, they're not actively working on all those individuals at any one time, because they may be in hospital, but we're waiting for other things. So that then enabled us to identify to that supported discharge team, but we put an additional assessment and review in as well. So it gives us a bit of resilience within that system as well, within that team.
Okay, great, because that's what I was going to ask about, you know, is there resilience if there's any sort of increase, I think, so that has been taken into account as well. Great.
But we've looked at the numbers over probably about a 2-year period. So, you know, we know that fluctuation is between about 40 and 60.
Okay, great. 5.7, we've undertaken consultation discussions with staff across adult services and trade unions around the new structure. I'm just curious, you know, what's been the feedback from those discussions and consultation?
really positive feedback. If you look at it, initially we provided through the RIF, we providing an additional 4 staff in the first instance through that supported discharge scheme. So, you know, everyone we consulted on thought it was beneficial to have staff dedicated to support that rather than it sort of being fragmented across the teams and trying to find out and sort of keep a handle on it. It will improve communication because you're going to have these staff based in the hospital, but only we will be focusing on Prince Charles and YCC Ysbyty Cwm Cynnan, because that's where our majority of our work comes from in terms of hospital discharge. We may get an odd one from Royal Glamorgan or from Ysbyty George Thomas, because the rehab for the stroke unit is based there. So if you look at it, the hyperacute for stroke is sited at Prince Charles, as Councillor Tuvey mentioned earlier, but the rehab is over in Ysbyty George Thomas. But we don't get a lot of referrals from those areas, so we'll focus on the 2 main hospital sites for us, which is Prince Charles and YCC.
Thank you, Angela. Councillor Clive Tuvey. Councillor Tuvey, you're on mute.
It's acting independently, I think. No, I agree with Councillor Thomas. Having a deputy manager was ideal, but how on earth did they manage when the manager was off sick? Because I can imagine there must be about 10 people or more working in these. And did someone sort of informally assume charge, or how did they manage? Because I couldn't see how, say, 10 people, you know, unless you have someone in charge, it's very difficult.
I think we were fortunate in some of them stepped up and did some of the basics, which was, you know, making sure the rota was done. The principal manager ended up having to step in with some of the areas. And it just highlighted how at risk we were by not having sort of managers who could, you know, sort of deputies who could step up into that. So, you know, it wasn't ideal at all. And in fairness, Claire, the one registered manager, Claire Barts, was really supportive and sort of provided some outreach. Initially, when it was in T-Gurnos, Claire picked up additional responsibilities. So even though she hadn't sort of been appointed into that post to cover the 2 areas, she was picking up a lot of responsibilities under goodwill.
Oh, that's good. Yeah. Okay,
Yeah.
thanks.
Thanks.
Just a quick follow on from Clive's question, then I'll hand over to Gareth. Those staff that stepped up and did you retain those staff? Are they still on board?
Yeah. Then Claire Barts, you know, she was appointed into the registered manager that covered 2 areas. So you know, it was really positive appointment there, and I think, you know, we can see if you look in the message this week, you can see some of the work that's been done within the care home sector with the appointment of the new managers, and the, you know, the significant work being undertaken. Certainly, some, because I sit with 2 hats on, you know, care management teams are reporting when they go into the care homes that, you know, the feel of the place is different, you know, is far more person-centered. So, you know, it is moving, you know, sort of in the right direction. There's still some work that, you know, we want to do, and, you know, got to give credit to Christy, who's a principal manager in that area, who's done, you know, sort of work with the home managers to significantly change the care home and the feeling within, well, not feeling, certainly the atmosphere is different within those care homes. They're far more vibrant than they were, and I know Councillor Jenkins is planning to go and visit this week, isn't it? And you be able to see the difference when you walk in there.
Thank you, Angela. Councillor Gareth Richards.
Thank you, Chair. I'm just a simple question. I'm a bit I want an explanation of 3.5. What does A1S or A1s and PPN?
That's our fault. That's my fault.
Yes.
Is A1s are the notification and PPNs are the notifications. So A1s are any referrals that go into our safeguarding team from, and it could be from a member of the public, it could be from a professional. And PPNs are the reports that come from the police. So if they go and there's the domestic abuse or an incident, they will send the PPN in to advise us that there's been an incident, so that we can look to check if there's anyone known to us and is there anything we need to action as a result of that report. My apologies for putting in abbreviations.
I'm just curious really what it was. Thank you, Angela.
Angela, I may be wrong, but this is how I've interpreted. So the principal manager post, so that's vacant at the minute. Yeah.
Yeah.
So
Well, we've got
with the
someone covering as an interim. Yeah.
So that was my question really. So who's picking up safeguarding at the minute?
Safeguarding at the moment is Joe Rees-Jones has been covering in the principal manager role as an interim while we were looking at what our options would be. And I know we looked at a number of options, one of which was replace as was. The other option was to look at the regional approach, which was an option, but no one that we progressed. And then one of the other options was then that we look at a team manager for that team and working, you know, sort of for adults, because the previous safeguarding, previous safeguarding principal manager covered adults and children's. So, you know, it was quite a big remit then to do it. Then we were thinking, could we do it, you know, sort of just look at the senior social worker in there? So it would have been too great a role for a senior social worker, so it would need to be a team manager to cover off and our responsibilities as part of our regional safeguarding board.
Thank you, Angela. And last one for me, 7.3, we need to revise our processes to reflect the new structure. So what does that mean? It just seems a bit vague. It just like...
It'd be too much detail to put in here. So if you look at it, what we're saying is like under WCCS, we'd have a process map then to say how someone moves through our systems.
Right.
So if you look at it with the hospital-based team, then what they'll do is they will pick up anyone that's in hospital apart from what are termed the like frequent flyers. So that we've got a quarter of people who are in and out of hospital but are still actively care managed. So it'd be farcical to reallocate those to the supported discharge team. So responsibility will remain with that social worker if it's an open case, but the team will provide up-to-date information and correspond with the social worker that's allocated. So then we need to like develop, put in WCCS, create the new team. Well, that new team is going to be how we workflow them through that team onto the longer term team. The other area we're looking at is, you know, some of the assessment and review team will move into the longer term team and look at undertaking reviews for those that are closed and on review. Yeah, so it's basically the background work we need to do to make sure it all works through the WCCS system and everyone knows how it's going to operate going forward.
Okay, great. And I think considering the other report we've had on this one, like realistically, with the discharge team, once they're operational and embedded, like realistically, when, because I would be interested perhaps in seeing like a review of how it's been since they've been in post and how were those delays, just to track that. So realistically, for some sort of review to come back to us, I was just interested what sort of time frame do you think that would be?
In real terms, if you look at it, we were hoping that we would have had these in post by September, but there was some delays in sort of getting the funding. So in an ideal world, we would have wanted this team in place in September to be fully embedded before the winter period. we need to provide evaluation information on the team to the regional commissioning board group because it's grant funded, so we've got to evaluate this continuously. So it'll be number of caseloads, you know, sort of whether it'll have an impact on delays, because as I said, the census is a really difficult thing to say about because it is a snapshot at like one point in a month. So it was only on that one day of the month, and things, you know, we could have the report the delays, but we could have had sort of 30 discharges the day before, but it doesn't recognise where people are moving. It only recognises where people are stuck in the system, or they may not even be stuck in the system because it could be completion of you know, waiting for a package of care, which is a good example, that they could be planned to go and be discharged on Thursday, but as of the Wednesday, that's the primary reason for them still being in hospital. And the same as the care home, they could be waiting for a care home, but they could be planned to be discharged in a couple of days' time. So it's a bit of a blunt. I'm sure we're talking to a lot of people across Wales. The delayed pathways of care is a pretty blunt tool to measure how effective we are in supporting people through flow, but it's one the Welsh Government are really keen to reinstate and recognise it's not a great system. It would be much better if we could balance that off with saying, okay, we've got these many, but how many people have been discharged successfully and how many people have moved through quicker. But
would that be something that you would be tracking?
We will track it purely from our own point of view to see if there's other delays and seeing where they are. And having that senior post there, we'll be able to keep a track of that as well. So, you know, we do keep a track of people in hospital, and we've got a Teams set up with a spreadsheet on sitting in Teams that everyone updates. And we can, you know, sort of look at any one point to see, you know, that's updated like once a week to see what we are waiting for. So that should then be more current. So instead of being updated once a week by the team managers, it'll, you know, we hope that the senior social worker will be updated a couple of times a week. So it's more current information.
Lovely. Thank you, Angela. Sam, do you got any other questions before we move on to comments? No? Any comments? No? Thank you, Angela. I think, and I think echoing the comments of Councillor Ian Thomas and Clive, just the change in structure and having the deputies is smarter. And I know Jane is on the call, and I think it would be good for us to just perhaps make a note of a review of the discharge team perhaps next winter. Possibly we'll keep a track on that. Thank you, Angela. Lovely. Okay. Item 5 is the Forward Work Programme. So this is the latest version of the Forward Work Programme, and we have added the column for us to close the loop. But we just need to go in and populate that. So, and again, obviously this is a living document, and obviously it changes when we attend quarterly meetings, and things may happen that we want to add a pop on to the Forward Work Programme. And obviously it mirrors, you know, it's to make sure that we aligned with the Cabinet Forward Work Programme as well. Any questions or comments on the Forward Work Programme? No? Lovely. Item 6, scrutiny referrals. They've had no referrals at this stage, but again, any emerging needs perhaps are popping up with casework in new wards or things that maybe need further explanation, just bring those forward. Angela and Lisa, you can leave now.
Thank you.
Thank you. Thank
Bye.
you.
Bye.
Take care both. Take care. Bye. Okay. So item 7, report recommendations. So recommendations for 2.1 was scrutiny, just to note the contents of the report. And I think we've done that quite well. Everybody can unmute themselves if they want. Or are we happy that we just noted the contents of that report?
Yeah.
Yeah. Do we all think, are we all happy to perhaps track the discharge to assess team somewhere along the line in scrutiny, like how it's embedded? Are we all happy to kind of take that forward?
Yeah, it's a good idea, yes.
Yeah.
Yeah.
Okay. Lovely. Item 4, the review and reconfiguration of adult services. And so this is listed to go into Cabinet on the 8th of November. I don't think there's anything that's come up which is overly concerning. I think we asked some good questions and we've had some really good answers from Angela. Sounds like this has been long overdue, this structure, doesn't it? Yeah, we all happy that we noted that.
Yes,
Yeah.
yes.
And I think Angela gave a very good rationale as to the reconfiguration. So lovely. Right. So item 8, feedback on scrutiny activities. So on the so Councillor Claire Jones brought this forward because coming up we have a report on mental health services. And I think that it was to look at services which are given money from the authority to deliver projects, etc. And Snakes and Ladders was raised. So that's why we've arranged for them to come and have a chat to us. So that's on the 14th of November and that's face to face. It's informal because there's young people, is literally just to come and have a chat to us. I'm going to speak to the manager to see if they would prefer some questions in advance because of the young people, just to ease their anxieties as well. But yeah, it's just completely informal. And I've asked Jane to see if we can get some cake and biscuits and whatever, just, you know, so it's nice and relaxed for them. So that should be really nice. So they've given up their time to come and meet us. So it'd be great if we could all attend. I think some people have accepted already, which is brilliant. We haven't had any dates yet for other external visits because I know we got some penciled in with some reports coming up. But as soon as we get those dates, we'll circulate those because I know in the new year there's a visit planned to the Campus Neighbourhood Learning Centre in the Gurness. Item 9, any other business? I have none. So that's it. Thank you. And thank you everybody for switching to Teams. Very much appreciated today. And I'll see you all soon. All right.
Thank you.
Take care, everybody.
Good night, all.
Take care. Nice to
Good
see you all.
Thanks,
Take care.
everybody.
Bye.
Cheerio. Thanks.